All right, so like Jaron, I'm a pediatric guy, so I wouldn't have operated on any of the adults either. So that's just sort of my caveat into where we're going with this. So if you look up the word deformity in the dictionary, it's a condition in which a part of the body does not have the normal or expected shape. And synonyms are a flaw, a blemish, distortion, disfigurement, and defect. However, we don't know when that deformity becomes a problem and we need to operate on it. So that's what we're looking at now. And Jaron has done a real good job when we talk about AIS. In spinal deformity, the main type we're talking about in kids is just talking about scoliosis and kyphosis. And mainly today we're just going to be talking about the scoliosis stuff. Scoliosis comes in many different shapes and sizes in kids. You get idiopathic, which is broken out into the adolescent, the juvenile, the infantile, which is now more classified together as the early onset scoliosis. You've got neuromuscular, you've got congenital, and you've got syndromic scoliosis as well that you can throw in there. Kyphosis has the many different types, the Sherman's, the post-traumatic, iatrogenic, post-surgical, congenital, and neuromuscular as well. And so when we look at curves in general, and we've got kids here all in their adolescence but these curves are all the same, right? I mean, when you're looking at them, they're all curved to the right. They're all in the adolescent population-ish. And so they should all be looked at the same. But I would tend to look at them as totally different when you look at all of them together. And so with adolescent idiopathic scoliosis, when you're talking about spinal instrumentation and fusion, like Jaron had already talked about earlier, we're talking about those kids that are around 50 degrees in the thoracic spine. Some would say consider 45 in the lumbar spine, and some would say actually with a lower Cobb angle for those in the lumbar spine with such a large truncal shift or a clinical deformity that's present. If there's no deformity, or if that intervention is not had, then those will progress at about one degree per year, as Jaron had discussed in the Weinstein papers. This can lead to pain, worsening deformity, back, lung, and heart problems that he had sort of talked about before that may or may not really be true that go on. You can get those big problems with the cor pulmonale, right heart failure with those huge curves. You get pulmonary functions limited in those severe scoliosis that are greater than 70 degrees due to the chest wall deformity and the lack of the thoracic, and because they've got thoracic lordosis and the lack of kyphosis, they're decreasing the lung volumes. There is a higher rate of back pain in those adults with AIS, as Jaron had talked about. That's been highlighted in multiple studies with the ones by Weinstein. And then the psychosocial impacts. There's been some studies out there that say there's a lower marriage rate, self-image issues, and parental unacceptance of this. A caveat to this is it's not necessarily just in the U.S., but it's also around the world. We had a patient when I was in fellowship who was brought over from Saudi Arabia, and parents brought her over there to San Diego so that she could have her surgery so that she could get married because no one would want to marry her with her current spinal deformity. So it is sort of an issue, a psychosocial impact issue. So AIS, that Jaron had already highlighted earlier, we'll sort of cruise through this. 19-year-old female there on the left, a 15-year-old male in the middle, and then a 15-year-old female on the right, all with different curve patterns. All of these meet the surgical indications for surgery. And so they get a spinal fusion, the left one being a full fusion, the middle one being a selective thoracic type fusion, and then the right one being a larger fusion based on our Cobb angles and the flexibility. I do actually, even though I'm a pediatric guy, I have the privilege of working with my adult colleague. He helps me out with all my AIS cases and my pediatric patients, so I get to help him occasionally with some adult patients with deformity as well. And so I get to see sort of the adult sequelae of AIS as well. And so here's a patient, 32-year-old female that he just recently walked in the door that saw him. She's a female. She's had AIS when she was younger, and now this is where her curve is going. So she's got a progressive curve that's continuing to progress just as Weinstein sort of predicted in the future. Here's another patient that he recently saw, 40-year-old female. She actually had surgery back with a Harrington rod that was placed and then removed, but now she's got continued deformity below it and it's continuing to progress as well. So the articles by Weinstein that showed that adult sequelae with the progression do continue to occur. And so we did take care of this this lady. She's a 40-year-old female that we did and did a fusion with her, and she's doing very well now. So now we'll sort of transition out of what Jaron had talked about into what juvenile infantile idiopathic scoliosis, or what's termed now as more of the early onset scoliosis. But these indications are much more variable. And the goals of the surgery are to control the spinal deformity, allow for continued growth if possible, and delay any spinal fusion if you can. The interventions, just as the goals, are very variable as well. This is all based on the curve size, the growth remaining, and the progression of the curve as documented. And so for juvenile infantile idiopathic scoliosis, the interventions are lots of different options. So you've got bracing, you've got Risser casting, you've got growing rods, which are sort of taking more of a backseat out of the magnetic rods. You've got the Schiller rod techniques, where you fuse a local segment and then let growth go above and below it, and you've even got the VCR that you can do. And so these interventions are sort of numerous that you can have before you do the fusion. These curves, the reason to do surgery on these is if they are progressive. Conservative interventions have failed, and they're sort of a moderate to large size curve with trying to do some sort of a growth preserving technique to allow for these curves to continue to grow and not limit their pulmonary function. So here's a patient who came in to see me. He was a year and 10 months old. Shortly after I started, I saw him and talked to him and his family. I wasn't doing a lot of casting at that point, and talked to him and said, hey, you need to go up to a different facility and start doing some casting. They didn't do that. He came back at 3+2 with his curve worsening, and then 3+7, it continued to worsen. So we decided to put him in a cast, and so I do a casting technique where it's sort of a hanging cast, so we hang him from the ceiling, and basically it's a side bending cast. And so we put him in a cast. This isn't necessarily his cast, but this is a cast similar to what we put him in. He's doing just fine with it. Helped basically just control his curve. And so now he's at 5 and then 5.5 years old, controlling his curve at least a little bit. It's not progressing a lot worse, but we're trying to get him to grow until we can finally do his fusion. He's probably going to get magnetic rods here probably in the next 6 months to a year, because parents are getting a little frustrated with casting. And so that's part of your issue as well, as dealing with the parents. So adult sequelae of juvenile idiopathic scoliosis, another of my adult partner's patients, is a 49-year-old female. She was diagnosed at 6. She was braced until she became mature. And when she was mature, her curve was about 50 degrees thoracic curve, 50-degree lumbar curve. And we can see that curve, as Weinstein had predicted, has continued to progress. And so now she's left with a larger operation, increased morbidity, harder to get her to fuse with more complication rates and a bigger surgery because she's more stiff. And so I would say that she probably should have had a surgery done when she was younger to help out this, because it's going to be a little harder to do now. And so next we'll transition to the neuromusculars. So the goals of the neuromuscular patients are to get them good sitting and standing balance if they are standing, encourage their independence. Good example is the kids that are in the wheelchair who are leaning on their left arm. They need to have that arm to be able to use and feed themselves, not to be able to keep themselves propped up. Assist mobility, whether even if they're walking or whether they're just doing transfers, to try to help them with that. Prevent any progression from occurring and maximize their cardiopulmonary function. Improve their hygiene and improve patient and caregiver quality of life. The older literature, if you look at it, really states there's really there really is no different indications than those of the AIS patients. So usually, if you look in literature, it says a curve of greater than 50 degrees, they should be fused as well. There's really no new literature regarding this subject, but the risk of progression is very high in those neuromuscular conditions, and we'll talk about that, especially in those cerebral palsy patients. I was involved in a study where we looked at some proactive versus a reactive approach to patients, and whether it's good to do those patients when we notice that risk of progression to be greater than 50 degrees, or if we wait until the patients and caregivers are having significant challenges and then we do the surgery. And this is actually going to be published later on this year. And so when we look at this, what we found out is that being proactive and doing those patients less than 70 degrees had really no advantages. There's really no decrease in the risks, and there's really no improvements in the quality measures overall. However, if we wait, and we wait until they're doing a reactive approach, until those curves are greater than 90 degrees, we have multiple issues. They have increased risk of infection, increased blood loss, increased need for anterior and posterior surgery, increased operative times, and trends towards a lower quality of life overall. So ideally, the surgery is recommended for those curves that are less than 90 degrees for those patients. And so ideally, anything between 70 and 90 would be perfect. And so we do know that in the neuromuscular patients, especially those with cerebral palsy, the GMFCS level classification system is very correlated with scoliosis. We know that those patients that are GMFCS level 4 and 5, which is depicted in the bottom two portions of the picture there, show that with the GMFCS level 4s, they have between a 40 and 60% chance of scoliosis that's going to progress. Those patients that are GMFCS level 5 that are dependent for all their care, those are going to progress to 60 to 80% of them developing a scoliosis that is going to require surgical intervention. And so here's a 15-year-old male, GMFCS level 4. So he was in high school at the time, planning to go to college, independently, manually moved his own wheelchair, was in the National Honor Society of school. He had a large lumbar curve that's there. He underwent a fusion and is doing very well now, going to college at Wichita State and doing very well after his fusion. Here's a 30-year-old GMFCS level 5 patient with cerebral palsy, large deformity that's there. We did his surgery here just recently. He's doing very well with no issues whatsoever also. Here's a 14-year-old male with Duchenne's muscular dystrophy. His curve, though, is quite a bit smaller, as we know, and we'll sort of touch on this a little bit later, that these neuromuscular cases, their curve should be taken care of at a much smaller indication due to the fact of their pulmonary status. And there's his surgery after we were all done. This keeps him upright and able to function well for whatever years he has remaining. Next, we'll talk about congenital scoliosis. We all know there's the difference between the failure of segmentation and the failure of formation, leading to the different vertebral abnormalities. The worst would be a combination of this with, of course, a hemivertebrae on one side and a unilateral bar on the contralateral side. And so that's the one that you definitely have to do an operation on as soon as you can. We also know that with a segmental hemivertebrae, there's almost always progression of this, and this is usually always recommended for a surgical intervention. Usually this intervention is done between the ages of 3 and 8, if you can get it at that point, if it's picked up. These used to have to be done from an anterior approach, but now most of them are done with the posterior approach. You can do a localized fusion on that level and take care of them that way. The unilateral bar usually always progresses as well, and this is usually treated with a localized fusion of those levels that have the bar. We want to make sure that indications are, of course, if there's a neurologic deficit or if there's a declining respiratory status as well. 3D CT scans are very helpful for those patients you're thinking of operating on, especially if you're talking about doing some sort of vertebrectomy or resecting that hemivertebrae and knowing where that's at and the indications for that. So here's a patient, 6-year-old female hemivertebrae. We can't hardly see it there on the left side picture, but on the right side picture you can sort of see that segmented hemivertebrae that's there. She underwent a localized resection. Here's a CT scan of it right there and an MRI showing the hemivertebrae that's there. We resected it and did a just localized fusion one level above, one level below, and she's doing fine, no issues whatsoever. Actually her compensatory curve that we could see down below is actually starting to improve now as she grows. Here's a congenital patient, 11.5-year-old with a congenital bar. Previously seen one of my partners when he was 11 and a half, didn't really notice anything. He came to see me after I fixed his meniscus. And parents started noticing that his curve started getting worse. And so we sort of looked at it at 14, and then at 14 and a half, we noticed it continued to progress. And so got a CT scan. And what we did find out is that he does have a congenital bar there. But we also noticed that if you look at him real close, he's also got a congenital fusion of L3, L4, and L5. So he's got all kinds of different issues going on. We did a localized fusion of him, trying to keep as many segments mobile down below because he doesn't have a normal lumbar vertebrae. We fused him there, and he's been doing very well ever since. Syndromic, when you look at those patients with the syndromic scoliosis that does increase their chances of having scoliosis, there's lots of those, Prader-Willi, Marfan's, neurofibromatosis, Angelman's, Down syndrome, especially those that have the congenital heart defects that are repaired. That alone by itself is a higher risk of having a scoliosis. Prune belly, Ehlers-Danlos, there's a whole host of these that can go on. And there's really, these are all extremely variable, and there's really no set indications that are different than any other scoliosis except for the Duchenne's muscular dystrophy. Those are usually talked about as fusing them when they get a curve of 20 to 30 degrees, or if they're doing fairly well on corticosteroids, you can even wait till 40 degrees. But we want to operate on those patients before their pulmonary function declines. So here's a 12-and-a-half-year-old male, Down syndrome, history of congenital heart defects. If we look real close, you can sort of see the sternal wires that are there. He had a scoliosis. We fused him, and he's been doing just fine. Here's a 5-and-a-half-year-old female who initially came in to see me because she had a clubfoot history of torticollis, and parents thought she was walking funny. And then when I looked at her before she went, right as she was walking out the door, I said, well, her back looks a little different. So she stopped, and we talked a little bit, and come to find out she's got neurofibromatosis type 1. And so we watched her real close, but we noticed that after a year that her curve started to progress. And so we then put in the magnetic rods, and we've controlled her, and at 7 years, we implanted the rods, and now she's 9.5, and we've controlled her scoliosis at this point, trying to get her to the point where we can get her old enough to be able to do a final fusion on her. And so when to operate on a child with scoliosis depends totally on the type of scoliosis, the progression, the patient's age, the maturity, the curve size, the neurologic status, and the functional impairments that is being implied by them or their parents. Thanks.